Good afternoon, and welcome to the Care 360 sponsored webinar, Should I Stay Independent or Join the Hospital? My name is Colby Dix, and I will serve as your moderator and host today. We have a lot of material to cover in this hour, and we're very pleased to have Mark Anderson with us, presenting on a pressing topic that has crossed many of our minds in light of the ever-changing state of healthcare. Our agenda today is on the screen for you now, and we will dive directly into Mark's presentation shortly. There will be a Q&A session directly following. Please also stay with us for a brief overview of Care 360's complete suite of healthcare IT solutions to close out the hour. I'd like to extend a warm welcome to our presenter today, Mark Anderson. Mark's bio is up on the screen now, and you can see that we're very lucky to have someone with such experience available to us. His 40-plus years of dedication to healthcare IT and consulting has earned him great renown in our industry. And as the CEO of AC Group, throughout his career, he has consulted with literally thousands of physicians and hundreds of hospitals. Welcome, Mark Anderson.
Well, glad everybody was able to join us today. I'm up in lovely Denver today, meeting with a couple of hospitals on their purchasing physician practices with perfectly timely discussion here. As you can see from my bio, I've been involved in healthcare and technology for over 40 years, but in the 1990s, when I was part of the corporate team of a couple of hospital chains, we were in the process of buying up physician practices, and I worked with the physicians to determine, should they become employed, should they stay independent, how the contract should look, what they should be doing. And the interesting part is in the 1990s, we actually ended up hiring over 1,000 doctors. By the late 90s, we ended up giving all the practices back. They all became independent again. And there's a lot of different reasons for that. We'll talk a little bit later on today. But we're back in that realm again where hospitals are looking at buying practices. And we're even seeing today more practices are going to the hospital, asking the hospital if they're willing to buy their practice. So in the 1990s, the hospitals are going after the physicians. Today, we see a lot of physicians going after the hospital. So it's kind of an interesting combination we've seen over the changes over the last 20-something years.
Yeah, it's definitely an interesting topic, and as you say, it's something that's affecting us in a different way now than it was even 20 years ago, but still a trend that somehow has reversed and come back again. So.
And we'll talk about the reasons why it's reversed and coming back again and why it's important for doctors to at least think about it. We're not saying one way or the other to do it, but we're going to give you some good pointers today on what to look for, why is it happening, and why you want to think about staying independent or joining the hospital. A lot of it's cultural issues that you want to think about too. But we're going to go into all that today's session.
So looking at the session today, we will be asking 8 distinct questions relating to physician ownership. The intent, of course, is to give you deeper insight on the challenges that both independent and hospital-based clinicians experience, as well as highlighting the potential benefits to both of those. So I say we dive right in, starting with question 1. A seemingly general question, but there's plenty of nuance to this just below the surface. Mark, what are the major factors affecting physician ownership right now?
I think there's a lot of different things as we have bullet pointed here that are going on, and we have some slides coming up that will actually go in a little bit more detail. But there has been a challenge the last few years about supply and demand for primary care physicians. We have less supply than the demand is out there, and we've seen some changes where we're hiring more PAs and nurse practitioners. We seem to have a lot more specialists. In the United States, we have 7 specialists for every primary care physician out there today. You go back to the Scandinavian countries, it's completely opposite. They have 7 primary care doctors for every 1 specialist. So there's a lot of trends we're seeing in the United States about physicians not wanting to be in the primary care business, probably because they feel they can make more money as a specialist. They have more prestige as a specialist. But again, we need more primary care physicians because we're moving to a new financial environment, which is all about value-based reimbursement, quality of care, trying to keep people healthier. And from all indications out there, we need more primary care doctors to really work with the patients to try to stay healthier. In the past, we got paid to take care of medical conditions. In the future, starting in 2018, we're going to start getting paid to take care of the health of a patient, not necessarily just their medical condition, but try to find ways to keep them healthier. And there's all kind of interesting financial information out there, physician-run versus hospital-owned ambulatory practices, which ones are cheaper, which ones make the doctors more money, which ones have better quality. We'll talk about some of that. The other part is hospital balance sheets are becoming very stressed. You know, over 1,000 hospitals are facing bankruptcy in the next year, according to the American Hospital Association, based on the information they're sending to the cost reports that are required to go to CMS and Medicare. When you think about it, we could actually lose 25% of our hospitals the next year unless the hospitals find a better way of financing how they deliver health care in this market. So if hospitals looking at buying practices, if they can't even stay open, what value does it do for them to go out and buy physician practices? They think there's a value, but we're going to talk a little bit about that. Again, we see that hospital purchasing of practices has actually increased healthcare costs. So as a physician is employed by a hospital, you would think that there would be some overhead cost reduction, but we're actually seeing increased costs when the hospitals own the physicians. But there's also cultural managers we'll talk about, and all kind of things to do with evidence diversities that we need to really look at what's happening out there and what's going to be changing in the near future. So we have a slide for each one of these as we go forward. So we talk about one of the big issues has been the increase in cost, and this is a study that's always done every single year showing what the costs for a family of four are. And you start looking back in 2002 compared to 2017, so basically 15 years, the overall cost for a family of four, this is money out of their pocket, has gone up 186%. And during that same time, salaries have only gone up 35%. As we all know, and everybody keeps talking about, healthcare costs are going up faster than anything else out there today. We have to find a way of changing that. The interesting part is, you know, everybody kind of talks about we have a lot more baby boomers going into Medicare. That's why costs are up, because we have more people. But this is the actual out-of-pocket cost for a family of four. Who can afford to pay for all this when the salaries aren't increasing at the same level? And one of the challenges we run into is because healthcare costs in the United States is about 4 times higher than in other countries over that we call the G8. Again, it's because we do not really pay for health. The insurance companies pay when somebody gets sick. We wait for you to get sick, and then we basically take care of you. That has to change. We have to find a way of keeping people with chronic diseases like diabetes, CHF, asthma, obesity, you know, that they don't have as many issues. If I can keep a patient out of the emergency room one time throughout that year, I can save enough money for 20 office visits. So it's all about keeping the person out of the hospital, out of the emergency room, trying to keep a little bit healthier. So again, we got to find a way of cutting this cost down. But that's what's driving a lot of the changes going forward. The other part, I'm not sure how many of the doctors and office managers really know about, we're moving to what's called value-based reimbursement. It's an alternative payment plan that Medicare and CMS came up with a couple of years ago, and Aetna, Cigna, United, and the Blues are all implementing this new reimbursement model starting in 2018. So what we're seeing is fee-for-service, which is about 80% of all the business in the 1980s, is dropping. And by 2020, it's going to be about 18%. What's going to happen is doctors are going to get paid for taking care of chronic disease patients on a capitated volume. In other words, you're going to get maybe $100 per month per patient for like diabetes to take care of that patient. You don't get paid for the visit anymore. It's a true capitation model. It can be condition-based, like you have diabetes. It can be partial population, where you're taking care of 5,000 diabetic patients, or it could be for all populations. So all populations right now is very small as far as capitated, but the movement to value-based reimbursement, where you're paid based on quality and outcomes, not based on the services that you provide, is going to be changing. And that's going to drive a new requirement for physicians. And as we'll talk about a little bit later, most of the contracts for value-based reimbursement are going to large physician groups with at least 500 doctors, or to the integrated delivery networks, hospital systems that own maybe 5 or 10 or 20 hospitals and employ 500 physicians. So if you're not part of that group, you may be missing out on a lot of business in the near future. So again, what does all this really mean on this shifting reimbursement landscape, which is the reimbursement model? As I mentioned, we're moving from fee-for-service to an outcomes-based reimbursement model. And that can actually affect your decision, because the payers are going to contract with different organizations, typically hospitals or large physician groups. Small practices will not get that contract. The larger hospital chains will get it. Think about that if these contracts go to the larger physician groups or larger hospitals, you could lose up to 50% of the patients that you're seeing today. Anybody that has any kind of chronic disease could be reassigned to a hospital system and their physicians. And the other part that's going to happen is reimbursement is going to continue to tighten. Most doctors realize that the amount of money they're getting reimbursed by the healthcare plans and CMS is not raising at the same rate as costs to run the practice. You have a lot of overhead. The average practice has 53% overhead now. We're back in the 2000s, about 20%, a lot more administrative costs. And to work in a outcomes-based reimbursement model, you're going to need new technologies. The EHR is just the starting point. You'll need care coordination, patient engagement, remote patient monitoring. All these additional requirements are going to be there. And it makes sense for the hospital system to buy these systems and let the doctors actually access them versus each practice going out and buying their own. It really doesn't make a lot of sense. But in 2020, the estimate is, because the number of people that are on chronic diseases, 68% of all patients will be tied directly to one health system for all services. And if you're not part of that health system, then those patients will not come to you unless you are a specialist and you're the only specialist in the area. But there's that potential that you can lose business if you're not part of the healthcare system going forward. So, what's the prediction? The MD supply will diminish significantly while demand for the services will grow as chronic disease incidence and access to the ACA expands. Things are going to be changing, and you got to be prepared for that. And here's some graphs that kind of show what's going on. We start looking at the number of population to the number of physicians. We're kind of low, and if you look at the United States compared to a lot of other countries, a lot of these are the G8. A lot of difference in our number of physicians we have per 1,000 population. But you start looking at the bottom graph there. Doctor visits are sharply higher for those over 65. And we know we got a lot more baby boomers coming in to the over 65. And why is that? That's because typically people that are young, from 5 to basically 54, don't have as many office visits because they're not as sick as other people are. When you hit 65, like me, you get a little older, things start hurting more. And if I've got Medicare and I've got a supplement, it's 100% covered. Why not get all the tests done? So we seem that us, compared to other countries, we do a lot more work on people over 65 because Medicare is covering a lot of it. And with the supplements, for a couple of $100 a month, I get all my health care paid for. Why not go for it? So we do see a lot more. And since we have more baby boomers coming in, we're going to have a lot more tests going on for older people. The other part that's interesting is the physician age. Physician workflow is aging. 250,000 active physicians are over 55 years old. So we have a lot of doctors that are basically old enough that they're starting to think about retirement. They're thinking about cutting back their services, maybe not working as hard. And we have a lot of less physicians coming into the market. First year MDs enrollment per 100,000 populations has really been declining, and it's expected to be down to almost 5 by 2020. We have very few doctors coming into the market compared to the population that's still growing. And part of that's because a lot of people now think that being a doctor is great, but it's so much administrative burden, so much cost involved, so much work you have to do. You don't have the time to take care of the patients. You're mostly doing administrative things, your paperwork today. So a lot of the younger people are saying, I don't want to become a doctor anymore. But hopefully that'll change in the near future. So we kind of talked about the supply and demand. This is a study that was done in 2016, looking what the supply and demand is. And the supply right now is growing a little bit. But by 2025, we're going to have about 750,000 active physicians. Now, this does not include PAs or nurse practitioners, but the demand is going to be over 900,000. So you can see the gap there. Now, that can be filled in with PAs, nurse practitioners, or cutting down the number of visits we have to do by keeping people healthier. But the demand is there, and the hospitals know this. And so the hospitals are saying, to meet that demand, I want to employ the physician so I can control what they're doing. I can control what patients they see. My philosophy has always been the doctor should be in control. All the hospital is another facility that doctor can take patients to. You've got your office, you got ambulatory surgical centers, you got emergency rooms, you got hospitals. It's the place that the doctor decides to take their patient to. But from an administrative point of view, the hospitals think we're the big facility. We're everything for the doctors. If the doctors didn't have our hospitals, they wouldn't have any place to go. I think that's false. I think that the doctors drive it all. But again, as we move to this kind of new environment, doctors are more independent. They don't get together as one big group to go after things. But if you're an IPA or an MSO, you may have more power. As an individual physician, you're going to be kind of following what the hospital administration wants you to do, not what you want to do. If you're seeing patients within the hospital, or if all the contracts go to the hospital, you're going to have to follow what the hospital says, which is probably a bad thing for the physicians.
Yeah, I think that's really important to note. You know, even just as so many physicians want to remain truly independent, that it's becoming even harder to do so based upon, you know, those pressures, certainly the bureaucratic ones, and as you mentioned, of course, you know, the baby boomers and that increasing patient population. But the baby boomers are the doctors as well. So the doctors themselves are aging out, and that's another one of those. As they edge towards retirement, it becomes another shortfall in the physician population, and another very real concern that will have a ripple effect throughout the industry, not just in terms of the patient care, but of course, and the cost of care. You know, it all comes down to, at the end of the day, it trickles right down to the pocketbooks of all of us who are showing up to get our treatment.
That's correct.
Mark, let's take a look now at the recent history of practice ownership and even some of the longer-term trends. Has physician ownership changed significantly in recent years?
Yes, it has. As I mentioned earlier, back in the 1990s, there was a lot of activity going on. It'll be on the next slide. That showed when hospitals were buying up the physician practices. And that's really changed, I'd say really since 2006 it started going up. But you can see from the graph, now it kind of really peaked for a while, went back down, and now it's going back up. And actually 2017, we've seen double the number of acquisitions that we saw in 2015 and 16 combined. So hospitals are thinking about buying more physician practices, and as I mentioned, physicians are actually going in trying to be employed by the hospital because they can get rid of a lot of the administrative burden, the regulations that they have, dealing with malpractice. Let somebody else do that. Let me practice medicine and let somebody else worry about the administrative side. So even though the graph is showing it going up as of 2013, it's twice that high now in 2017 with all the acquisitions that went on just this year. So there have been more acquisitions in 2017 than all of 16 already. And 15 and 16 are going to add up to about the same as we're expecting for 2017. So it's increasing dramatically.
So I know, Mark, that you've already kind of touched on this some, that there is a bit of a trend with the physicians actually reaching out to hospitals and looking to get acquired, but still the kind of anecdotal concept of the hospital acquiring a number of physicians seems to belie an attitude of volume-based care still being the prime motivation. Just saying, if the more doctors we have, the more regular patient visits we have, then it'll even out from the hospital perspective. And do you think that
yep.
tendency, though, with us moving certainly more towards a value-based care plan, do you think that are hospitals really? I mean, are they a little behind on their thinking, or is it something where are they going to be able to adapt quickly enough to make up for the rapid changes coming in terms of value-based reimbursement?
Well, I've worked with over 200 hospitals on this specific question, and I think a lot of them are trying to get prepared. But when I asked them about, well, we did this in the 1990s, what's different now? Their typical answer was, what happened in the 1990s? Most of the hospital CEOs out there were not around in 1990 to know what happened and why it worked and why it didn't work.
Yeah.
So I think they're not quite prepared. What they're learning is the healthcare plans are coming out and saying, you have to have at least 500 doctors. You have to cover these geographic areas. If I give you 5,000 or 10,000 diabetic patients, how can you provide the amount of care in these geographic areas? And a lot of this ends up being in kind of remote areas too, kind of the urban and rural areas. So that the hospitals are like, oh, we better get more doctors in, mostly primary care doctors, and people that can cover, again, chronic diseases. They're not looking for doctors who take care of the average healthy person. They're looking for people with chronic diseases. That's where the money is, and that's where the trend is moving. So they're looking at picking up people that endocrinologists or heart surgeons, some orthopedic and rheumatology. They're not necessarily looking for the average surgery or for OB/GYN unless that person has a chronic disease. And obviously obesity is another big one that they're looking for. So they're looking for a certain type of doctors, and the assumption is the primary care doctor will become the gatekeeper, and therefore we need to hire more and more primary care doctors to control where they send the patients to specialists. So a lot of things going on in that market, but you're right. Value-based reimbursement is driving a lot of this push right now. So as we kind of talked about, the hospital ownership of physician practice has actually increased 86% in the last 3 years. Now, what that really means is about 67,000 practices were now, from 2012 to 2015, are now owned by the hospitals. These were practices that were kind of independent. And that really represents about 140,000 physicians altogether. A lot of them are 1 and 2 doctor practices. It's hard for a hospital to buy a 15-doctor or 50-doctor practice because it gets expensive. But you walk into a doctor, 1 or 2 doctor practice, and say, look, I know you're struggling, you're making X amount of money today. Let us just take over your practice. We'll give you a little bonus for signing up, and we'll pay you the same salary or a little bit more than you used to make. So a lot of the smaller practices say, that sounds good. But again, you've got a lot of value in that practice. You could sell your practice to another doctor for more money you're going to get out of the hospital. Think about that stuff, though. But again, there's a lot of people, a lot of physicians that are moving to the hospital systems. And right now, we're at 38% of physicians are now employed by a hospital, according to certain reports. In 2010, that was 17%. So just in the last 7 years, we went from 17 to 38% of all physicians are now employed. And that's going. Everybody's expecting that to increase to 50 to 60% in the next few years. And the government already states that 67% of all doctors are employed. That's a false number. What they're doing is they're surveying university settings, Kaiser, Mayo Clinic, and of course most of those are employed because they're one system. But overall, according to American Physician Association, American Medical Association, about 38% are employed. So that'll be over 50% by 2020. So why, as we really talked about a little bit, why is it all changing? And I think, again, it's the change in the new reimbursement models that all the healthcare plans are talking about. CMS has already stated that 50% of all payments are going to roll to value-based, quality-based contracts starting in 2018. And remember, CMS, the Medicare program, the year starts October 1st of 2017. So we're only talking a few months away where the amount of money that Medicare pays for services are going to switch from fee-for-service to value-based contracting. And it may not be in every area, but it's definitely going to be in the urban areas. We have multiple hospitals competing for that business. But we know that CMS really favors integrated health systems opposed to independent physician practices. All of the MIPS and MACRA are kind of built around larger groups. All the care coordination, patient engagement, remote patient monitoring. Patients don't want to have remote patient monitoring from 4 or 5 doctors. They want to have one system where that data can go to the primary care, the GI doctor, the endocrinologist, the cardiologist. They want the data to flow seamlessly to whoever I may have to go to. And remember, the average chronic disease patient is seeing 4 patients, 4 different physicians during that care treatment plan. So there's a lot of different people involved. They want them to be all part of one system going forward. So again, the other interesting part too, I think, is that large systems, physicians have some support staff, but as things get more sophisticated around outcomes measurement, quality improvement, patient satisfaction, either the doctor's going to have to hire more people for that administrative burden of reporting, or again, you work for the hospital, let them worry about all that. So it's going to be very hard for small practices to thrive in this market unless you have something that's very unique that the hospital cannot offer going forward. So there's another study done in 2017 by PwC, which is one of the big accounting firms. They surveyed a bunch of, it was like 35,000 doctors. They found 66% of all physicians want to be more closely aligned with their hospitals. Yeah, everybody can kind of see that. That doesn't necessarily mean I want to be owned by them, but I want to be closely aligned with them because we know that the contracts are going to that healthcare system. But 63% of cardiologists want to be employed by the hospital, which is interesting because a lot of their business is doing heart surgeries or catheterization procedures. They like to be tied to the hospital. More important, I think, is 58% of primary care providers want to be employed by the hospital. That's up from about 12% in 2010. So again, we're seeing in each one of these categories, more and more of the doctors say, I'd rather be employed by the hospital, all the way down. And 79% of all physicians surveyed thought that they would become more integrated with the hospital in the next 5 years. Again, the trend is to get away from being independent, but my philosophy has always been, if the doctors would just get together as an independent physician association, IPA or MSO, you can stay as a physician-owned organization working with the hospital. You don't have to be employed by the hospital, worrying about how the hospital does things, worrying about all their committee structures. I'd rather have the doctors running the whole thing. But the doctors have to come together. And the best organizations I've seen are IPAs. I did one up in New York, had 2,300 doctors. I did also one in Los Angeles that had 2,500 doctors. They controlled everything. They got the contracts for the healthcare plans. They decided which hospitals they want to work with. To me, that's better than you relying on the hospital to make the decisions on how you're going to provide care. But that's a challenge physicians have. If you're independent, it's hard to come together. That's why I always say, too, before you decide to join a hospital, maybe look at joining an IPA and see what they're going to do for you.
I think that's a really important distinction as well, to not think of this as a black or white issue, even though, of course, our title even almost presented it as such, independent or join the hospital. But there are indeed some other alternatives that should be considered moving forward. There are different formations and different types of groups that can still get you some of those, I'll call them economies of scale, or some relief from some of the bureaucratic aspects, but still allow you to remain independent as a physician or clinician.
I mean, you think about all the reporting you have to do, all the government regulations, and all the audits you have to go through. Let an administrative team do that. They don't have to be part of the hospital. You don't have to be employed by the hospital to do it. But it's easier, like the IPA had up in New York. We had a whole administrative team that handled all the paperwork for all the doctors. You can consolidate billing if you wanted to do. You can stay independent if you're part of an IPA, Independent Physician Association. But too many times the doctors don't come together, and it's easier just to be employed by the hospital. But again, you lose your autonomy out there. You become one of the masses, and the hospital decides who gets the business. And to me, philosophy-wise, it should be the physicians who are deciding that. But you can't do it as a 2 or 3 doctor physician practice. You have to be a larger group to thrive in the market going forward.
Yeah. Too many moving parts not to. The next slide dives into the percentage of doctors that by specialty that are more likely to be looking at hospital employment right now. This one I find quite interesting, actually, and I know Mark has a lot more to say on it.
Yeah, it's interesting that the most interested in employment, again, cardiology, psychiatry, surgery, OBGYN, again, a lot of their business is done inside the hospital setting. Obviously, emergency physicians, the same thing. But, so you can see them wanting to be employed. The interesting ones are the ones that least interested in employment. Radiologists, even though they work mostly in the hospital, they want to stay independent. Neurologists, gastroenterologists, and the big one I think is orthopedics and urology. We find that the GI doctors, the orthopedic doctors, urologists, and neurologists, that bottom 4 there, a lot of them have their own ambulatory surgical centers. A lot of their business can be done in an ambulatory setting, and they may own that building. Yes, under Obamacare, they stopped allowing doctors to own their own hospitals, which a lot of these groups did in the past. If you could be sunsetted in and still own your own hospital, but once certain things change, the doctors can no longer own their own hospitals. But you could own your own ambulatory surgical center. And think about that. We are now doing total hip replacements, total knee replacements in an ambulatory surgical center with within a 24-hour stay. By the time you check in until you leave, that used to be a 7-day to 14-day stay in a hospital setting. So we see more and more of the neurologists, gastroenterologists, orthopedic doctors, urologists. I want to stay independent because I can control what I do in my own ambulatory surgical center. The other organizations either see a lot of the patients in their office or have to go to the hospital setting. So I think there's an interesting division between that. But the typical hospital are looking for that primary care doctor, the internal medicine, the pediatrics, the OBGYN. They want to get all that because they know whoever controls the family controls where they're going to go for other kind of things. And obviously family practice is kind of like right in the middle. 46% are considering interested in being employed. So I think it's an interesting combination by specialty is a little bit different. And it all changes. Depending on what your specialty is, there's different ways of looking things. And there is no one answer. There's multiple answers, but it all depends on you, how you want to practice, who do you want to control your practice, and how you deliver medicine. If you want to stay independent, there's ways of doing it, but you can't do it the same way you've been doing it the last 5 to 10 years. Too many things are changing for a physician to stay independent, thrive in this market, especially if you're in an area that there's competition of the hospitals controlling a lot of the market.
Before we jump into question 3 here, I just want to make a quick note to assure everyone on the call and on the live session that indeed we will be sending out the deck and the materials from this session to you via email just after the session. So thank you for all of your questions, and please do keep the questions coming for the Q&A section later on. But for now, let's get into some of the differences between hospitals and independents. Some we've touched on and some are more obvious than others. But Mark, I know has some great points here, specifically on the economic motivators. Can you go into some of those differences for us, Mark?
Yeah, the next slide kind of shows some of the financial differences coming up in a second here. But yeah, there's a lot of things you have to think about from the hospital's perspective compared to the physician's perspective. You know, the doctor is really worried about the reimbursement cuts that are going on, where your costs are going up higher than you're getting reimbursed, because everybody thought that healthcare was recession-proof, because no matter what, people have to have healthcare. But one of the big changes has been the patient deductible. In 2010, the average deductible was $1,500. Today, it's $7,500. And I just found out last night that my daughter, who is a healthy female in college, her deductible is now $13,000. When is she ever going to spend $13,000? And all that comes out of her pocket before the insurance company pays a dime. And it's very hard for doctors to collect from patients. We're good at collecting from the insurance company, but collecting from the patient is very hard. So even though we always say healthcare is recession-proof, now you got to collect the money from the patient, which is going to drive up your costs. You need more IT support, more things going on, more people to collect from patients than you do from the insurance companies. There's also a lot of rising malpractice requirements around this too, because now the EHR is tracking every single thing you did and every single thing you didn't do. So there's more and more cases of malpractice out there with doctors who are using EHRs in the past. So there's a lot of different things you have to really worry about. People also were obviously worried about what's going to happen with the ACA Act, Accountable Care Act. So is it going to stay? Is it going to go? Is it going to be reformed? Who knows? And we all thought it was going to change as soon as the Trump administration came in, but Congress can't seem to make up their mind what they want to do. So there's a lot of stuff politically that are affecting doctors. What's going to happen this year? What's going to happen next year? Plus a cultural thing. A lot more younger physicians are coming in worrying about what they're going to do. They want to have a nice combination of work life and personal life. So they're more willing to work for hospitals, work for big universities or larger groups. They don't want to really run their own business anymore. Because, again, this is running a small business. And the cost for running a small business is escalating tremendously. And they're getting away from practicing medicine and worrying about the administrative side of everything. So it's really driving doctors to really rethink, do I really want to be in the medical field or do I want to try to do something else? On the opposite side is the hospitals. It's kind of like we call the herd mentality. Everybody's buying doctors. I guess we should too. They don't know why they're buying. They don't know what the right ones do. They're not doing financial statements on it. They're just saying we need to go do that. And the challenge they run into is the income statements. You have to have enough money to go out and buy practices because now you got to pay the doctor. And remember, you don't get paid typically for 90 days after you actually see the patient. So if they have enough money to float all that, becomes a big issue for them. They also see issues dealing with hiring of the physicians. Physicians have totally different contracts. They're considered an employee, but not really an employee. We need more care coverage. Hospitalists coming in. You may be a primary care doctor that covers patients in your office. Now you're asked to do 2 nights a week, 2 nights a month on coverage for certain things. A lot of big things are changing, but because of the Accountable Care Act and ACOs, Accountable Care Organizations, more hospitals are saying we need to do something. Let's figure out how we're going to do it, but we got to do it by improving outcomes, improving quality, not improving volume. And that's a totally different perspective from what physicians think about, what hospitals think about. And again, you ask the surveys that are out there, ask the doctors, 95% of physicians say losing their wealth is their primary concern. You know, again, why are they worried about losing their wealth and their income? That's because, again, as we already talked about, different regulations around profits, big new rules and regulations coming out there, Medicare coming in and doing audits, asking for money back, liability issues that are really popping up. Again, downward pressures on incomes. 86% of physicians think that they're worried that their income will be reduced, the amount of money that they make. Overhead costs for a physician in 2010 was about 32%. Now it's 58%. That's just to cover your overhead. Not one of that dollars goes to the physician. So for every dollar you make today, 58% goes to overhead. That means you're going to get 42%. Where in 2010 you were getting over 70% of that money was coming to you. It's really going down. You have to do more business today than you ever did to make the same money you made in 2010. And everybody assumes that over time you're going to make more money because escalating costs. Nope, they're actually making less money unless you see more patients. And again, 70% of practice acquisitions have actually come from physicians presenting themselves to the hospital. So as I mentioned earlier, physicians are now saying, we want to be employed by the hospital. Would you consider it? Where in 1990s, it was 100% hospitals going after the physicians. Now we see a difference, physicians coming after the hospitals. So a lot going on. The interesting part, I thought, was that 31% of physicians believe that we need to move to a single-payer system will help us cut a lot of this. It's hard to believe that doctors want to go to a single-payer system, but if you really kind of look at Medicare, it's a single-payer system for people over 65 or 66, depending on what year you're going to be in now. But again, it's a single system. It's easy to get paid. We don't get paid a lot of money for Medicare, typically 33 cents on the dollar, but they typically pay within 2 weeks. Typically, there's not all these denials and issues going on with it. It's a simpler way of getting paid. But is that the right way? Do we want to have one payer system? Do we want to take choice away from patients? Probably not. There's a lot of things going on that really drive the doctors to be worried about how do I control my income going forward.
A big question that affects all of us in some way is around the cost of healthcare. There's an assumption that there are some of those economies of scale that I mentioned earlier in the hospital system, but that's not really always the case. Mark, how does physician ownership affect the overall medical cost?
Well, you're right. The assumption was if I'm owned by a hospital, they'll cover the overhead a little bit easier and we're able to reduce some of the costs down. As you'll see on the next slide, the statistics show something totally different. So we started looking at, and this is data from back in 2010, but the numbers haven't changed that much, so we're trying to get the new numbers. But so if you look at the best physician-owned groups, that's the very first column, non-hospital-owned groups, and compared to the rest of the hospitals, IDNs, the physician-owned groups, so compare the first column to the last column. Overhead for a typical physician office for the better office is 58%. In a hospital-owned physician group, the average of the hospitals, the majority, the 80% rule, 83% of the cost is overhead now. So much more that they throw in there because you have to cover the overhead of the hospital, the office, and everything else that they're doing, more than anything else. Gross charges per full-time equivalent physician. For regular practices, gross charges is about $1.3 million on average per year. Doesn't mean that's what the doctor gets, that's just the charges. We see a decrease in productivity by about 80%. Rest of the hospitals, you're not getting as much money because, again, once you're employed by the hospital, the requirements for how many visits you do actually goes down. If you're making your money off of how many people show up in your office, how many procedures you do, you make sure that your calendar is full all the time. What we see in a hospital setting, since you're getting a salary, if somebody no-shows, you don't try to fill that position, fill it with another person coming in. The average physician office has about a 7% no-show rate. An average physician office owned by the hospital has a 28% no-show rate because they really don't follow through on it. There's not a penalty if you don't show up. So we see the actual charges going down for the physicians. Same thing with RVUs. We're seeing a lot less business going on for physicians that are in private practice compared to the average hospital organization. Probably the bottom line is the bottom number. The average MD revenue after all the operating costs, again, it's just for an average physician out there, taking all the physicians all the way, $351,000. Organizations, hospitals that own physicians, they're making a total of $69,000. Now, if that hospital is paying you $300,000 a year and they're only making $69,000 in actual revenue after expenses, then there's a problem out there. They're going to be losing money. Why does a best practice physician group make $351,000 per doctor, and the rest of the hospital only makes $69,000? Because again, they do a poor job of collecting, poor job of keeping that doctor busy. In an average university setting, the average doctor sees 7.2 patients per day, compared to a private practice that may see 40 to 45 patients a day. So a lot of interesting statistics going on out there, but doctors make more, as far as their revenue coming in, make more as a private practice. Practices that are owned by hospitals, the doctor makes, not necessarily the doctor, but the revenue that comes in after expenses decreases tremendously with a physician that's owned by the hospital. Doctors still might get paid the same, because that's just your contract. The hospitals could lose money. Another interesting fact that most people don't realize is if I'm in private practice, I see the patient today, and I admit him to the hospital tomorrow, the hospital gets paid and the doctor gets paid. If the hospital owns a physician practice and that physician sees the patient today and admits the patient tomorrow, that doctor, the hospital cannot bill for that doctor. It gets all rolled in to the DRG under Medicare and Medicaid, which is more of a per diem rate. All of that doctor's revenue gets rolled into that DRG. Therefore, we don't get paid a dime for any visit where a doctor sees a patient, they admit the patient to the hospital within basically a 24, 48, in some cases 96 hours. All that gets rolled into that one payment that comes from the hospital side. Again, the hospital makes less money if they own the doctor, but they feel it's still beneficial because they can control where the doctor sends their lab tests, the radiology, who they refer to. Plus, they want to be able to expand their market to say, we cover this larger geographic area by employing the physicians. Doesn't mean the hospitals are going to make money off of this. Right now, the numbers show the hospitals are going to lose money. And if you kind of look at this graph, it shows really the differences on how many procedures are being done. Kind of look at the bottom line number again. For every single office visit type thing, the typical doctor would make $1, which is the second, or I call it the third column. Because, again, any profit would go to the doctor anyway, so it's kind of like the profit margin is $1. In a hospital-owned physician practice, the hospital will lose $21 per office visit. That's a variance of $22. So, again, if the hospital owns the doctor, the hospital actually makes less money than the doctor on private. But the hospital still sees as a positive by controlling the network. So, doctors, if you're looking at doing this, make sure you get a contract that has a very good salary range and not necessarily a salary plus incentives around volume, because no one wants a volume anymore. They want to reduce the volume by keeping people healthier. So if you're looking at doing it, make sure you get somebody who specializes in this kind of stuff. I think I've done over 1,000 contracts with physician groups and hospitals, but get somebody who knows how to write the right contract for you to protect you. Most of the contracts are written to protect the hospital. It needs to be written by you, for you, to protect you. And as I mentioned earlier, the problem has been with hospital balance sheets. If they go out and hire all these doctors and we're losing $22 per patient visit, what's going to happen to the bottom line of that hospital? Well, if that hospital is making $20 million a year or $50 million a year, they can afford it. But like as I mentioned, if there are 1,000 hospitals are facing bankruptcy, you can end up getting employed by the hospital, and within a year that hospital goes under. Then what happens? Sure, you're back in private practice, but you may have to start over with a lot of different things. You don't have contracts anymore because all the contracts are with the hospital. You got to go back and build all the contracts with the payers again. Maybe those payers have already created a new contract with somebody else. So again, you want to be with a hospital chain that can afford it, that's going to be around. Don't take the word of the hospital they're going to be around. I see a lot of big hospitals that have negative financial growth. And if they're buying practices, paying for it up front, and paying for the doctor and losing money on every single visit, they're not going to be able to keep that up forever. Things have to change. So there's been a lot of things on what about the cost? And there's been really limited evidence that hospital-owned practices influence healthcare costs positively. Again, most of the numbers are still showing that the costs are going up. But as we move towards this new model around value-based reimbursement, where we're not worried about volume, we're more about quality and outcomes and how the patient feels, then volume doesn't matter that much. And we hope that under this kind of model, where we get the healthcare plan, the hospital, the doctor all working together, kind of like in the Kaiser plan, the Mayo Clinic or the Cleveland Clinic plans, that we get better outcomes, lower the cost of healthcare, make sure patients are seen more rapidly. Do you know that if a diabetic patient gains 2 pounds from Monday to Tuesday morning, there's a 71% chance they're going to have an ER visit within the next 7 days? That's facts that are out there that the different American College of has figured out. There's a bunch of research out there on these kind of things. Why? We need to be tracking the weight of that patient, not waiting for them to come into the office, but tracking it on a daily basis, having that information come into a care coordinator who could coordinate the care between the physician's office, the emergency room, the patient and their family. And doctors can't do that on their own. They need a bigger network to do this. So again, an IPA or being owned by the hospital or tightly affiliated with the hospital is the only way to thrive in this market going forward.
Yeah, and we can look into our, the crystal ball of the future, and while so many of us do have, whether it's a smartphone or a Fitbit or something of that nature, and are more and more, we're surrounded by relatively easy ways to track a lot of that sort of data, exactly the kind of thing you're talking about, whether it's weight, your caffeine consumption, BPI, stress levels, all these other things that are just key indicators that if you see a change outside of a standard deviation, if you will, that would highlight or even alert your doctor automatically. And we look forward to a technology that really does marry those daily interactions that all of our patients and all of the people that surround us, our family, our friends, interact with in a way that becomes more meaningful and actually more actionable. Because I think, as you said, it's not just at that point. It really is win-win. We're talking about the quality of care for everyone, but it also brings down the cost of care, which just has to happen because we're all feeling the pinch on that front.
That's correct. And that's it. These remote monitoring systems have been out there. People have smartphones. They have the little bracelets they wear on that can do their vital signs and things. We can send an alert to you telling me, hey, Mrs. Jones, don't forget to take your green pill at 2 o'clock today. Things are going to help improve overall outcomes. Right now, once the patient leaves the office, we have no idea what's going on. We don't know if the patient picked up their med. We don't know if the patient's taking their med. We don't know if the patient's following any of our clinical protocols. We wait for them to show back up in the office and go, yeah, I gained 20 more pounds, even though I was on this weight reduction program. It just didn't work because I didn't follow it.
Right.
I can't wait 3 months to find that out. We need to know immediately what's going on with the patient. And that can only be done with larger healthcare systems because there's not a simple way for private practices to track that kind of information.
And backing away from the financials just for a moment, we can talk about some of the cultural differences. And there's a pretty dramatic difference in the way that a small business or a small practice is run versus how the hospital is managed, which I know you've already touched on. But could you go into some of the more intricate values of the cultural difference?
Yeah, if you think about a physician, they like being independent. They make the decisions. They're authoritative. They can decide what they're going to do, when they want to do it. They like rapid decision making. Tomorrow I need to do something, I'm going to go ahead and do it. They've been trained on the medical side. They weren't really trained on the small business side. They don't really know how to, they're trained to where they work independently, not as a committee. Versus the hospital side, it's all about embracing the organization mission, values, and the vision they have, avoiding any kind of conflict. They're not going to take any kind of risk, and they really like the hierarchy that, if you're in surgery, you got to report to the head of surgery who reports to somebody else. It's all about committees. Hospitals are run by committees versus a private practice, you're run by the doctor. The doctor makes that decision. And all of their training has been really around social activities, management services, managing the people. They're not around, and again, delegating the work to multiple different people versus being a doctor who makes the decision. Every doctor is their own CEO. In a hospital setting, they may be 5 levels below the CEO and can't make those decisions. And in a hospital setting, I've worked in 200 hospitals. We have more committees managing other committees than anything else. I used to spend 35 hours a week in committees, and ends up that hardly anybody would make a decision because no one wanted to be held responsible for that decision. In a private practice, the doctor's always held responsible, and they're willing to make that decision much quicker. So everything moves a little slower in the hospital setting. Everything is decided by a committee. They'll decide how many patients you see, what medications you give, what lab orders. And doctors say, look, I'm the one that's been trained on this. I want to do what I want to do. I want to stay independent. But you're not independent if you're employed by the hospital. There's ways of making it maybe a little bit more independent with your contracts. But again, the hospital makes that final decision on what's going to be happening. But as we move to value-based reimbursement, the healthcare plans are going to be signing with that hospital to provide all care. Therefore, the hospitals decide who they want to deliver that care. And again, if you're not part of that hospital system, you may lose out on your patients because that hospital may end up going with a different doctor who might provide different quality outcomes or have a different use of a computer system that they're going to like better. So it won't be based on you're a great doctor. It's going to be based on how well you integrate in with that hospital system. So it's a big challenge for everybody. And again, hospitals have always emphasized value over productivity, typical things. Yes, they want to make sure the patients come in, length of stay, but again, they get a lot of reimbursement now around the quality, the outcomes, making sure our readmission rate is very low. We get paid a percentage based on how well the patient thinks about the hospital. And we're going to see that really increasing dramatically. It's not going to be about how many days you stay and how many surgeries you do or how many ER visits you actually drive to the hospital. It's going to be more of, for the chronic disease patients, how much less work do you have to do to get a higher quality and outcomes indicator. If the patient does not have a chronic disease, it's still going to be fee-for-service. We want you to bring those patients in. But if they have a chronic disease, and they're part of that value-based contracting, where I don't get paid for services, you're going to have to learn how to cut back services while improving outcomes. And it's not for all patients, only the ones that you have that contract with. You may have 5,000 diabetic patients. Another hospital may have 5,000 CHF patients. It doesn't mean the hospital is going to get all the contracts, but you got to learn how to work with all of that as you go forward.
Right on. And now, back to the financials, but from a very different perspective, if you will, and definitely an important one. But from the physician's perspective, will my annual salary increase if I join a hospital?
Well, that all depends on how good you're at negotiating contracts. So as we've talked about already, more and more hospitals are losing money on the physician. So they may offer you a lower salary, but we're going to cut the overhead costs. We're going to take care of all the healthcare reform issues that are out there. We're going to make sure that the financial model is better for us. But again, when they're thinking about it, they're thinking about the hospital, not about the physician. So a lot of this depends on how much money they pay for your practice. In most cases, if you're a primary care practice, we really don't want to pay a lot for the practice. We may pay you a small stipend, like a signing bonus, and we may pay you what you made last year minus 10% or 20% for overhead, because we're going to take care of all that for you, all the hassle. So a lot of doctors may come back and say, I don't mind getting paid less because I don't have to work as hard. I don't have to worry about the administrative burden. But again, when you sign a contract, you want to make sure you get the maximum amount of money up front, and maybe you get some, I'll call it bonuses or quality improvement. If you meet their clinical quality indicators, you make more money. Remember, if they hire you and all of a sudden they're going to be dictating what your performance should be from a quality point of view, from a numerical point of view, an outcomes point of view. If you don't meet those needs, the hospital can fire you. And they will, because they're going to look for the best of the best to stay on. I may employ 500 doctors, but after the year, I may only have 400 left, or I may have 300 left. They're going to pick the winners and losers. And as an independent physician, you don't want somebody else picking if you're going to win or lose. So a lot of this is going to be out there, a lot of demand. Again, if you're in a specialist that there's a short supply, you'll make more money. But it's all about contracting. It's almost think of you as a professional football player getting the football season. You want to have that person who represents you when you go into those contract negotiations. Doctors need almost like an agent to negotiate, because you may have 3 or 4 hospitals you want to negotiate with. Don't go to just one. Consider who are the big hospital chains in your area, and have them compete for your time and your money. Because to them, you are money to them because you're bringing more business to them, helping them get more contracts. If I get you on as an employee, I may get more contracts, which can drive more money to the bottom line. You are money to them, and therefore you need to make sure you have that agent that represents you. Don't go in independently trying to get a contract with a hospital. Have somebody who understands this kind of stuff that can drive business benefits back to you. Yeah, they're going to offer you fair market value out there, but there's a lot of little things you can get. Are you going to have to be on call, covering other shifts? They always want additional doctors to be on call covering things, maybe in the emergency room or in the ICU area. But physicians may receive various benefits relating to their benefit plan. You may get a better insurance plan, better life insurance. They may cover your malpractice rates for you at 100%. And especially for small physicians that are just coming out of medical school, you may find out that they're going to pay you a salary that's a little bit smaller than you're getting paid today, but they may pay off all of your medical bills, all your medical school stuff. Instead of coming out and saying, I still owe $250,000 for medical school, get the hospital to pay off that debt. You don't want to have any debt going forward. Let the hospital pay for all that. It's a cost to the hospital that they can kind of write off when it comes to the Medicare cost reports, because it's a cost for acquiring physicians. So don't just think about salary costs. Think about salaries, benefits. What else can you get? Can they pay off some of your bills? Can they do certain things? Certain things they can do, certain things they cannot do. But as an employed physician, there's more things they can offer to you. And if you're independent, hospitals can't offer hardly anything because that goes against the Stark laws. So as an employee of the hospital, there's a lot of additional benefits you can get that'll make it look more beneficial to you. But just know most hospitals are not going to offer that unless you bring it up. Yeah, that's why you need somebody who's done this before.
That's an excellent point, certainly. And as we did say before, regardless of how we presented it initially, this isn't so black and white as, should I stay independent or should I join the hospital? And there are some alternatives, some sort of middle ground that you've touched upon. But what are some of those alternatives in a little more detail?
Well, we kind of talked a little bit about it earlier. You can join an IPA, independent physician organization. You can join MSOs. Physician groups kind of get together. So it doesn't have to be employed. It's really going to be who's going to control that managed care contract that we call alternative payment models, or on bundle payments or value-based contracts. Who's going to get those? Because that's the opportunity. If you are in a rural area and there's only a 20-bed hospital, you probably don't have to worry about it because that 20-bed hospital probably will not get the value-based contract. It's going to go to a larger tertiary hospital. And if you're the only primary care group, the only specialist in that area, they're going to have to work with you no matter what. But if you're in an urban area where there's a lot of competition, a lot of your specialists in the same area, and there's 3 or 4 major hospital chains, they're probably going to get the contract. And you don't necessarily want to sign up with the hospital until you know they get that contract. Because if you're an endocrinologist dealing with diabetic patients, primarily, or a primary care that has a lot of diabetic patients that are overweight and that kind of stuff, if you get employed by that hospital and then they don't get that contract with the healthcare plan, then they may not need you anymore because they don't have enough business for you. They're going to be making that decision. So a lot of times it's kind of like wait and see. Let's see which contracts go to which organizations. Whoever gets the most on, obesity and CHF, hypertension, you want to find out who gets those contracts and maybe work with them. But again, the alternative is not to do anything, wait and see what happens. Right now, I'll guarantee you this will happen. The Republicans and Democrats are united around changing our healthcare reimbursement model. Both are going to go with it. It doesn't matter. ACA could stay exactly what it is, and right now under the ACA Act, 50% of all payments are going to move to this new contract, and both sides support it. It's going to happen. And why? Because the statistics show, the financial numbers show, that the CMS, Medicare, Medicaid, and the commercial accounts have figured out that they're going to save 20% of their money by shifting the risk to the organization that takes on the value-based contract, traditionally large physician groups or hospital settings. So they're going to do it no matter what. So it's going to occur. It'll start in 2018. It probably won't hit 50% until 2020. But if you sit back and wait and do nothing, you can lose a lot of your patients within a 2-year period. So I would say sit back right now, but actively look at what are the alternatives for you. Personally, I would start with an IPA or an MSO. that has at least 500 doctors to make sure you're covered in that community. If it's not out there, start talking to the hospitals. What are they doing around value-based contracting? Because, again, if they're not going to bid on it, then don't even talk to them, because that business is going to go someplace else. But there are alternatives. You don't have to jump ship today. If you're a small physician practice just out of medical school, you probably need to look at alternatives going forward, because things are going to be changed in the near future. And, of course, the doctors that have 30 or 40 years experience have all this profile information that's stored in the healthcare plans in the hospitals. If you're a new physician in practice, you may need to build up your resume, and maybe working for the hospital is the best way to do it right now.
Then even just to touch on this just a little further and to get a little more granular, and then also sort of to mine one of the questions that came in earlier and pop it in there now, generally aiming at the whole presentation, but even in this in terms of alternatives. When we're speaking to something more specialized, such as a psychiatric nurse practitioner with an independent practice, maybe they have contracts with an Aetna, United Healthcare, a couple of the bigger players. Do you see that, depending on the specialty, is there a difference there as well as far as that type of outreach? And I suppose once again that comes down to population management, of course, and are there, if there's 15 psychiatric nurse practitioners in the area, that's a lot different than if there's 1 or 2. But at the same time, like that becomes part of your leverage as well, correct?
Right. And again, all of this is being driven around chronic patients with chronic diseases. So if they have, and there's basically 5 chronic diseases we're looking at right now: obesity, diabetes, CHF, hypertension, asthma, things like that. For instance, cancer is not part of this right now. So if you're specializing in cancer, don't worry about it. Value-based contracts is not going to affect it. It's not really affecting rheumatology yet, but probably by 2020 that'll be added in. So it depends on how many patients you have that have certain chronic diseases, and a lot of people have 2 or 3 chronic diseases. If they've got 2 or 3 chronic diseases, more than likely you're going to lose that patient. So go back and look at your practice. What percentage of your patients have chronic diseases? What percentage of your business comes from chronic diseases by healthcare plan? You need to have this kind of information. That helps you decide that if you're over 50% of your revenue comes from patients that have chronic diseases, then you better think about you could lose all of that. Just assume if you lost all of your patients that have those 5 chronic diseases, all the income that comes from them, how would that affect your practice? Some practices, 5% of their business. Not going to worry about it. Other practices, it's 60 to 70% of your business. That's what you got to worry about. So I'd start with collecting that kind of data first around your current population, looking at how much revenue, bottom line, not how many charges, what was your collection rate, dollars coming into your bank account by chronic disease, and see how it's affecting if that ends up being moved to somebody else. You got to start there.
Excellent. I appreciate that. Well, the final question today is sort of a general catch-all, but what else should we be concerned with?
I think there's a lot of things. Do you really want a large hospital system to really dominate the whole market, where the patient has no decision on where they go? It's a kind of thing. We want an open system. We don't want people talk about wanting a single payer system. We don't want a single hospital system. We like choices out there as a patient. And again, we may find out that employed physicians and the patients will not have a choice of where they send their patients to and where patients can go. Remember, that healthcare system is going to pick who the specialists are. So if you've got a lot of really good relationship with other physicians out there, specialists, those relationships might be strained because you can no longer send the patient to those specialists. And the patients are going to be upset because they like going to certain specialists. They will not have a choice because the healthcare plan is going to contract with that hospital. That hospital decides where all the patients are going to go. There's also an issue of, as a doctor, will the hospital be pushing you more towards performance goals? We've seen, like, in certain places, we want to get the patient in and out of the emergency within 8 hours. We want the length of stay to be so short that we're making money on it. Or we want you to stop sending business to maybe Quest and send it more to the hospital things. Do you really want the hospital deciding what you do, what medications you order, what lab tests you do? That's a concern to me. I want the doctor to make those decisions, not necessarily the hospital. And even though I've been part of the hospital system for 25 years, 200 hospitals, to me, again, the physician is the decision maker, not the hospital people. But ultimately, health care will cost more, which will drive all provider reimbursements, changing things for them. So we know costs are still going up. The only way to cut costs is to improve outcomes, improve quality of care. But physician reimbursement, what you're going to get paid, is going to be dependent on how well you're able to document that you provide better quality, better outcomes than the same doctor down the street. And how do you do that? Most doctors have never had to worry about that in the past. It's all about, does a patient like me? That's going to change to who has the best quality, and that's going to affect your reimbursement going forward.
Well, this was really outstanding, Mark. I appreciate the session a lot today. I thought we covered a lot of great material. In the interest of time, I want to let everyone know that's the bulk of Mark's presentation there, as we've cruised right past the hour mark already. I do want to open it up to questions from our live audience now. I do have one in here from earlier. This is a little bit general, but it's pretty recent to what we were talking about, and about what the difference would be then for direct patient care models in terms of seeing this in the future from independent to hospital-based.
Well, I think that the challenge is going to be physicians that are independent today decide how they're going to care for patients, when they're going to see the patients, when they need to come back in, who they refer to, what tests they order. If you're employed by the hospital, there's a committee that's going to decide all this. So direct patient care is going to be driven by what the committee says you should be doing, driven primarily around what people think best practices are. And again, you go to Stanford University, they have a suite of best practices. You go to Presbyterian Hospital Medical School in New York, they have a different set of priorities. So it's going to depend on who decides what those priorities are. And my biggest concern really is, from a direct patient care, the patient has no longer the ability to pick who they want to go see. The healthcare plan is going to sign the contract with a healthcare system. That healthcare system will decide which physicians they contract with or who they employ. And that healthcare system, through their committees, will decide which patients go to which doctors. So we're taking the power away from the physician and the patient and putting it in the arms of administrators and committees to decide how direct patient care is delivered. And that's probably not the best thing we need out there right now, but it's something that other people believe will help control costs. It's becoming a single medical system because that healthcare system decides what's going to go on. I think a lot of patients will not be happy with it. I think a lot of doctors will not be happy with it. But if it lowers costs by 20 or 30%, maybe people will put up with it.
That's a good point. Let's see, I have another here. It says, hi, Mark. It appears that being independent holds a significant amount of risk. What top two things do you think I should focus on to keep my practice healthy?
I think the biggest thing is, can you document in a quantified way that you provide better quality and outcomes compared to other physicians in the same specialist? If you have that kind of tool that can show that you've got better quality, better outcomes compared to somebody else, you can survive independently. The challenge we find is most doctors have no idea if they're better than somebody else. They don't have that kind of report card. And yeah, the healthcare plans have report cards, but they're looking at cost. What does it cost to charge? What did you order? In the future, it'll be about clinical outcomes. Who's reduced the A1C value of a certain patient by higher than somebody else? You may want a lot of patients with high A1C, high sugar values, because you can lower the percentage down more. But it's going to be about interacting with the patient a lot more, interacting with their patients, the families, care coordination, patient engagement, remote patient monitoring. Most doctors don't have the money to pay to do all that stuff. But if you can do it, you can stay independent. Or, like I always say, my number one thing would be look at joining an IPA, helping them organize, get better. The IPAs I work with thrive in this market. They're driving a lot of the decision making. We decide which healthcare plans we work with. We decide which hospitals we want to go to. We don't let the hospital decide that. But the doctors have to get together and become one entity with one voice going forward if you want to stay independent.
Mark, thank you so much once again. Your contact info is up on the screen now. For those of you in the audience, if we didn't get to your question today, we'll certainly follow up with you offline. And Mark does always make himself available to you. He's an outstanding consultant that you can certainly reach out to outside of this session as well. Someone well worth talking to in many ways. And we appreciate it greatly. Thanks again, Mark.
Thank you.
And well, now we need to turn our attention to our sponsor, Care360. Care360 offers a complete end-to-end solution for all of your practice needs. We focus on the business side of things so that you can focus on your patients. We connect healthcare organizations, community physicians, and patients to improve access to information and insights. Our applications work harmoniously to promote physician loyalty, provider collaboration, and positive patient outcomes. And because we're backed by Quest Diagnostics, you know that you can rely on a stable and proven partner. Our network is strong, connecting over 450,000 physicians and touching the lives of over 1/3 of all Americans every year. And the confidence and reliability that comes standard with every Quest Diagnostics Care360 relationship is easy to appreciate and to benefit from. Our holistic suite covers every aspect of your patient and practice lifecycle, from appointments and reminders, documenting a patient visit, verifying insurance and processing payments, and right through integrated follow-ups via our MyQuest patient portal. If you're looking for a complete solution from a single source, Care360 has you covered. Our electronic health record is an ONC certified, award-winning product that works extremely well with small practices like yours. It's cloud-based with powerful mobile integration to your smartphone or iPad, allowing you to work wherever and whenever it's convenient for you. The practice management side allows your front office to work more efficiently and to manage the flow of patients, keeping your practice organized and agile and linking directly to your EHR so that you can spend more time focusing on your patient and billable encounters instead of front office administration. And if you're considering an enhanced medical billing service, Care360 has an outstanding RCM product as well. Few things are as time-consuming for your practice as billing and collections. Handing off the more monotonous busy work can free your staff to focus on patients instead of spreadsheets. Trust Care360 to provide you with a solution that's up to date in the evolving trends and the changes in the industry. Once again, if you do have more questions about Care360, please do feel free to call or email using the contact information on the screen. And we thank you all for your attendance today. Of course, a special thanks to Mark Anderson and to Care360 for sponsoring the event. Keep an eye on your email inbox for additional seminars covering related issues in the near future. We thank you once again. This will conclude today's presentation.